PGI is a problem, and persistent wound discharge after the surgery is actually a patient's agony and a surgeon's nightmare equally, because surgeon doesn't want to see his patient oozing on day 3, day 4, and from there the problem starts. So we need to work on this very aggressively. But there is a lot of confusion in the literature, because it's rarely reported in the literature what is PWD and what is persistent wound discharge. And there is no conclusive scientific evidence despite having so many meetings of the international consensus on the infection. And there are no high-level evidence or articles available, because it's very difficult to do a case control or a randomized control study in this kind of scenario. And there's wide variation in the diagnosis and treatment in daily practice, and every surgeon has their own whims and fancies how do they treat this difficult problem. So the difference is that whether you over-treat or under-treat, the surgeon dilemma lies there, whether I should debride or I should keep it like this, or I should wait for some time. So that's the dilemma where every surgeon is hovering around for a week or 10 days after you start seeing your patients with a persistent wound discharge. So the current recommendation is that if the duration is 72 hours, like after 72 hours or 3 days, so usually the wound epithelializes after 48 to 72 hours. Even after that, if you see there's a discharge which is more than 2 by 2 centimeter on your dressing, that's called a persistent wound discharge. So at least now the definition is confirmed. We have this in the literature. And if you see, once you start following this guideline, you will see that the incidence has increased to almost 2 to 21%. Now you need to identify these high-risk patients before you start doing your surgery. The people who are having uncontrolled diabetes, HbA1c of more than 8, obese patients, they can have fat necrosis, malnourished patients, multiple surgeries has been done before, revision surgery, elderly patients, and patients who are having psychological problems are potential risk factor for the persistent wound discharge. Now I won't say it's a literature review, it's just an information what is available on the net, because we don't have too many articles of high-level evidence. So the incidence is around 21% if you follow the guidelines, and higher incidence after the revision total joint replacement. Usually wound drainage at 72 hours is a non-infectious disturbance in the wound healing, and reason usually is either anticoagulation or diabetes or a fat necrosis. But whatever literature available from 1973 to 83 shows that if persistent wound discharge is there, it shows a higher evidence of developing a PGI later on in the course of the patient's recovery. There's increased risk of readmission, hospital stay, costs, etc. there. And each day of wound drainage extra beyond 5 days leads to a higher risk of infection by almost 42% for the hip joint and by almost 29% for the knee replacement patients. So you need to be very, very careful and aggressive in this window from day 3 to next 5 to 7 days, very, very important for us. And my talk will be primarily based in this duration, what to do when we are stuck with this. So most of the literature says that if the discharge is there beyond 3 to 5 days or beyond 1 week, will lead to higher incidence of PGI. But not just PGI, even if there is no PGI, the functional outcome of the patient is also very, very poor as compared to the normal patient. So both the things are important, not just infection, but also the functional outcome is also very poor in these patients. So malnourished patient will have a higher risk. So you need to see all these 3 parameters in your pre-op workup. Serum transferrin level of less than 200 milligram per deciliter, albumin level less than 3.5 milligram per deciliter, and total lymphocyte count less than 1500 are potential patients who can have the persistent discharge after the surgery. Now we all know that if it's beyond 3 weeks, it's definitely a PGI. If it's second or third week, potential risk of PGI. And wound drainage is the first post-operative week is not indicative of PGI. It can be just delayed wound healing. So second, third week is definite, looking towards a debridement or something. First week you can wait for some time. So there's one case control study that's called leak study was done in the Netherlands, but there are a lot of problem with the study as well, because obviously with this so many variables, you cannot randomize patients and work in one direction. So in this study, they from day 3 to 5, if there is a persistent discharge, they did the patient wound classification, clinical examination, and CRP on day 5, 7, and 9, 10. And then categorize the patient in 2 different categories, whether to observe them or do a DARE procedure. If patient is kept in the observation period and they develop a systemic signs of infection, or the wound is not recovering well, they have to switch to the DARE. So, and they found out that over a period of 2 years, they could reduce the number of DARE procedures by just observing few of the patients. But the long-term study is still yet to come out. The long-term results are yet to come out for this study. So they give a very good classification, how to classify these wounds. So the grade 1 is just a stripe of blood on the wound dressing, which is probably less than 2 by 2 centimeters. So that's a usual scenario you can see on day 2 or day 3 of your dressing. So that's called grade 1, which is probably not very important. You can just leave it and probably change the dressing and see that probably next few days the discharge will not be there. Now what is the moderate? When it is more than 2 by 2 centimeter, it will require an absorbent gauze dressing, but without the need to change it every day. So that's called a grade 2 type of persistent wound discharge, where it looks it's almost drying up. So you need to change this every day. So that's a type 2 of the leakage PWD classification. Grade 3 is excessive, where you need to have one dressing change almost every day. So these are the slightly higher category of wound discharge, where you need to probably change the dressing every day and think of looking some other treatment modality as well for this patient. And what is grade 4? Probably you need to change the dressing from morning to afternoon. So these are the extensively draining wounds where you need to intervene very, very early. So if the study says that if you are the interval from the primary surgery to DARE procedure, the longer the duration, the more the chances of the PGI. So the key is that you need to intervene early. Second week is the key time when you have to intervene maximum for these patients. So we have unanswered questions that to what extent our wound drainage will impair the wound healing, and how will it impact the wound healing and the PGI, and where would the wound drainage actually originate from, just by delayed healing or from the wound inside, from the joint. If there are signs of infection like fever, chills, tachycardia, you have to intervene and you have to operate and do a DARE procedure. So usually a CRP level, if it is rising more than 3 days and persistently rising, it's a risk factor for infection. You have to intervene on these patients. ESR is not that reliable because it goes up and up to 19-20 days and then goes down up to 9 months later. So how to treat these patients? So you need to first stop the anticoagulant, correct their anemia, correct the glucose levels, correct the malnutrition. Negative pressure wound dressing is very, very advantageous for these patients nowadays. And if you see, this is one of the patients where we use the negative pressure wound dressing. That's the initial one. We put the dressing on the right side, and that's at around 7 days. It's neat and clean. Then change the dressing again, and this is at 3 weeks. Wound is well healed. So early intervention with negative pressure wound dressing, we use this for type 2 and sometimes for type 3. If type 3, if you see that your negative pressure wound dressing is extensively draining, then you have to switch to, it's a type 4 category, and then you have to go for a DARE procedure. The WHO has given the guidelines how this PICO dressing or the negative pressure wound dressing helps, because it prevents a barrier from the external environment, it removes the wound exudate, and it helps in the healing because it prevents the lateral tension on the incision and improves the lymphatic drainage and reduce the risk of wound infection and separation, that is dehiscence. So it's a very, very useful tool for all of us for grade 2 and grade 3. Now if you need a surgical treatment, then you have to openly debride and remove all the modular components and use a new one for them. So that's just last few slides. So this is one of our patient we have opened up. So there's no infection, just a hematoma inside, but still you have to clean everything, wash with the chlorhexidine or with the betadine and hydrogen peroxide solution, and then put a new component in. Usually after doing this, you have to go one size up poly, and that's this patient after the complete healing. So to conclude, 72 hours is the key. More than 2 by 2 centimeter of the drainage, that is a persistent wound discharge. You need to classify your wounds based on 1, 2, 3, and 4. 2 and 3, you can get away with the negative pressure wound therapy dressing. Type 4, you have to debride. You have to work on the nutrition of the patient. And don't start the antibiotics. And if there's any doubt, intervene early, quickly to save yourself and patient from the long-term complications. I thank you all for patient hearing.